Tim Rementer, Doctor of Physical Therapy, Orthopedic Specialist, and I'm going to review a wildly popular low back pain video by an orthopedic surgeon out of Ohio and give you my perspective from a physical therapist. I want you to be armed with the information so that you can avoid unnecessary treatment and imaging. Orthopedic surgeons are brilliant folks that just want to help, but their tools are surgery, injections, and medications.
Low back pain. When the patient comes to you for evaluation for low back pain, the first question you ask the patient, do you have any bladder or bowel problems? You want to separate low back pain or acute low back pain from cauda equina.
Right out of the gate, this is a highly important consideration, but the majority of back pain has nothing to do with this. Starting off with such a rare condition already primes the viewer to be afraid of their back pain rather than treating it for what it is, which is a problem that you can easily conquer by focusing on your movement. For my first question for patients with back pain, I prefer, how are you today, before I start asking about your leaking bladder.
Cauda equina is an orthopedic emergency. It needs to be diagnosed early and treated by surgery early. Make sure you don't miss cauda equina. Ask the patient about bladder and bowel changes.
All right, joking aside, this is spot on and it's something you definitely want to be concerned about, but it's just not the primary thing that we should be thinking about when we talk about low back pain. Cauda equina means horse's tail because some Latin anatomist from yesteryear thought that when the nerves came out of the spinal cord, it resembled a horse's tail.
If there's any concern, you need to get a stat MRI with a wet or a stat reading.
A wet reading on an MRI is when the radiologist will give you immediate results from that image rather than waiting several days. This is a neurosurgical emergency because permanent damage can occur. If you have permanent damage to the nerve that goes to the muscle in your toe or in your ankle, while it's incredibly annoying and you probably won't be able to sprint or jump high anymore, if that compressed nerve happens to go to your bowel or bladder, that disability that results is much more significant and life-altering, which is why we don't mess around with it. But again, extremely rare and not at all related to most of the back pain that we see.
Acute low back pain or low back pain with sciatica, where the pain radiates to the leg and to the foot. Both conditions are initially treated conservatively for at least 6 weeks by physiotherapy, anti-inflammatory, limitation of activity as guided by the pain, even if there's a big disc in the MRI. So wait 6 weeks.
We're only about 1 minute into this video and he's already talking about conservative treatment, so let's give it up for Dr. E. If you do have an extremely serious condition, you certainly don't want to be seeing me for physical therapy. But since those situations are so rare, let's see what Dr. E has to say about physical therapy's role for low back pain.
90% of the patient will resolve the symptoms in 1 month.
He's commenting here that 90% of people with back pain will recover in 1 month's time. But that's actually only true if it's your first time with back pain. If you have recurrent back pain, which is the case for so many, you're not going to fall into that 1 month all better group. And the biggest problem I have with this is all better by most physicians' definition. I don't want to speak for him specifically, but typically what people are talking about is they don't have pain anymore. Well, the reason that you had pain is because of things like a lack of strength in your spine, a lack of joint mobility in your vertebral column, your hips don't move enough. I could go on and on. Unless you address those things, then you're really not better and you're going to continue to have issues down the road. But in his defense, he's not a physical therapist, and if I were to do a video on different types of orthopedic surgery, I wouldn't really be getting into the nitty-gritty of the surgery because I'm not a surgeon and I don't know how to do it.
Smoking, depression, vibration increase the incidence of low back pain.
Smoking, depression, vibration all increase the risk of low back pain, but not to mention low back pain increases the likelihood of depression. So it's a chicken or egg, two-way street type scenario. We don't want to just assume that depression causes back pain because somebody has both of those. When you're disabled for so long with low back pain that was treated with the faulty medical systems process of giving you medication and injections and surgeries, it's silly to think that you're depressed and that's causing your back pain. When you're depressed because you're stuck at home and you can't do any of the things you want to do because you haven't been treated appropriately.
Intradiscal pressure change with positions. The lowest pressure when the patient is supine, the highest pressure when the patient is sitting, leaning forward, and holding weight.
This is why you need to be carefully evaluated, because your activities and your posture will impact your progress. I once had a male patient who was not responding to all the things I was doing. I was trying everything and I knew that it should have worked, but I couldn't figure out why. So I started to ask him way more questions than I normally would from the start of his day to the end. It turned out he was taking a 30-minute bath every night before he went to bed. Him being in the position for those baths was causing significant disc pressure, but it's not something you would normally think of, especially for a man to take a bath at the end of the night. Once we got that addressed, pain was gone, 100%, he was good to go. Now, had we not done that and he went back to the physician, he likely would have ended up on a surgical table somewhere.
Now, the patient comes with low back pain and had a history of cancer, so you need to get an X-ray and MRI, especially if the pain at rest and at night.
History of cancer, get an X-ray or MRI, especially if the pain's at rest and at night. This is spot on. But again, here we are 2 minutes in, and for a condition that he already said improves 90% of the time, the viewer is primed for two horrible conditions that can end in permanent disability and death. I would be terrified if I didn't know anything about back pain and I started watching this video for just 2 minutes. Make sure you always talk it over with your provider to get an understanding of their thought process for ordering whatever type of imaging or treatment that they're prescribing for you.
In case of renal tumor, you probably need to do a turiography.
He starts to go in and talk about renal tumors, same theme, terrifying condition, makes you want to get imaging.
The spine is a common location for metastatic tumors. The metastasis occurs in the vertebral body and it goes to the pedicle. Loss of about 30 to 40% of the bone mass should occur before we can detect the lesion on the X-ray. Loss of the pedicle bone will give us a wink sign.
It's estimated that about 40% of cancer patients will have metastasis to their spine. That being said, if you don't have cancer or a history of cancer, this is an unlikely cause of your back pain. I don't know if I'd bring up the wink analogy when I'm telling my patient they have metastatic cancer in their spine.
Patient has infection. Infection will occur in the disc space. The segmentation rate and CRP will be elevated. Only 50% of the patient will have fever, and less than 50% will have elevated WBCs.
Spinal infections, I've seen 2 in 20 years where they were missed and sent for back pain. And the person had 104 fever, and we immediately sent them out to the emergency room where they had to have instant surgery to basically keep them from dying because they had such a bad spinal infection and abscess. So while physical therapists don't treat those conditions, we're trained to know how to identify them and to know when it's not a problem that we can treat. We'll send you right back out.
If we get infection post-surgery, you can diagnose it by C-reactive protein.
Infections after surgery, I think we know the best way to avoid those.
How about osteoporotic fracture? When osteoporosis starts causing fracture, you start with the wrist, then the spine, then the hip. So if you have an osteoporotic spine, you want to treat it before it goes to a hip fracture later on.
Unless you're in your mid-50s or you have some type of a chronic corticosteroid use for a different condition, it's really unlikely. If you're not at risk for osteoporosis, the key here, what he's talking about, is going to be that early screening in that 65-year-old range. The DEXA scan at 65 for women, and every 2 to 5 years after is the recommendation. People can be overscanned. DEXA scan was ranked as one of the top 5 most overused tests. It should not be used for women under 65 without risk factors.
After 1 year of treatment with medication, you decrease the incidence of vertebral fracture by 60%. After 2 years, you decrease the incidence by 40%.
Even if you are diagnosed with low bone density, many of the drugs that they prescribe for bone density carry significant side effects, so make sure you discuss that thoroughly with your physician.
So in general, when you're dealing with a patient with low back pain, you treat the patient conservatively. Don't get x-rays in the first 4 to 6 weeks unless there are some red flags, such as patient is older, or patient have metastatic tumor, or the patient has history of cancer, or infection is suspected, or the patient has trauma, or osteoporotic fracture because the patient is taking steroids. So you get the x-ray.
If you come to see us directly, because you don't need to go to a physician to see a PT, you come to see us directly, we know when we need to send you back out to your physician because it's outside of the scope of what we can do.
So you're going to get an MRI at a certain point for the spine? Well, you need to start first with x-rays. MRIs are a little problem.
MRIs are a problem. That's the best thing I've heard him say so far. Everything he said has been truth, but everything he said makes people afraid and want to get imaging. I'm glad he's coming out and saying that MRIs are a problem. They produce labeling and they make people afraid. When you hear you have a diagnosis from an MRI, you want that diagnosis fixed, and typically that's going to be through a surgical intervention. If you take a piece of your disc out, which is what they'll do in most spinal surgeries, you've created a void and you've lost stability and you've lost shock absorption in your spine. So it's only a matter of time in most cases where that's going to be a problem above or below.
Because number one, there are abnormal MRIs in asymptomatic patients. It is false positive. 35% in patients less than 4 years of age, and 90% positive MRIs in asymptomatic patients that are more than 60 years old.
Even if you do get an MRI, be careful. A study from the Journal of Spine, which is one of the most reputable journals in all of orthopedists, had the same individual go to 10 different MRI centers, and they found 49 different findings. Not one finding was the same across all 10 radiologists, and 1/3 of findings were found by one radiologist only. Same person, 10 MRIs, 49 different findings. I'll let you draw your own conclusions.
The second problem is the MRI with a dye. Gadolinium will differentiate a disc from a scar. Both granulation tissue and the recurrent disc can look alike on routine MRI. There will be contrast enhancement when there is granulation tissue because it's vascular. So there will be contrast enhancement.
Even if there's a big disc in the MRI. The problem I have with this comment is that, again, it's priming viewers to be on the lookout for these major problems and to request imaging early on in their rehab. Even though he talks about the fact that you need to wait to have imaging and that you should do conservative treatment early on, there's this constant focus on your X-ray findings, your MRI findings, and it makes the viewer feel like they can't move on with their life until they get an image that shows what's going on in their spine.
And if the recurrent disc causing a lot of pain or symptoms to the patient, then you probably need to do surgery.
This is everything you need to know about the horrible possibilities that could be going on in your back. But if you want to know about your likelihood to actually improve, which is most of the time, get yourself with a physical therapist who's encouraging and treats you by getting your movement to be the way it should be. Looking at your strength, looking at your mobility, and getting you to do the things, back to doing the things that you love without pain. If you like me doing this type of video and want to see more of it, please put it in the comments below. List in the comments any failed treatment you've had for your back pain over the years, whether it's injections, surgery, list them all. I want to get a good discussion of the failures of low back pain in the current medical system. In 2019, the CDC said 39% of Americans dealt with low back pain. His video, although it's very accurate and informative, covers only about at most 2,000 of those 39,000 cases that we see for back pain every year. The cause of the other 37 to 38,000 are missing from this video. Subscribe. Want to see some exercises you can do to alleviate your back pain? Click up here. Subscribe to the channel where I expose the truth on musculoskeletal health. Click here. You want to keep improving, you got to keep it moving.